This is Andrew from FX Medicine. We thank you so much for your support over the last 2 years. We'd really love to remain clinically relevant to your practice. So if you know of an expert in some area, please let us know. You can contact us on fxmedicine.com.au, Facebook or Twitter. This is FX Medicine. I'm Andrew Whitfield-Cook. Joining me on the line today is Dr. Nirala Jacobi, a Bachelor of Health Science and naturopath from the USA who graduated from Bastyr University in 1998 with a doctorate in naturopathic medicine. She practiced as a primary care physician in Montana for 7 years before arriving in Australia. Nirala is considered one of Australia's leading experts in the natural treatment of small intestinal bacterial overgrowth, or SIBO, a common cause of irritable bowel syndrome. In 2013, she participated in the Delphi panel at the first SIBO Symposium in Portland, Oregon, and will be a presenter at this year's event. She is also the main organiser of the first Australian SIBO Summit held in Melbourne and Sydney in October 2016. Nirala is the Medical Director for SIBO Test, an online testing and educational service for practitioners. She lectures nationally and internationally about the assessment and treatment of SIBO. Welcome, Nirala. How are you?
I'm great. Thanks for having me, Andrew. It's wonderful to be here.
Our pleasure. Now, I first have to ask you, we're going to be delving into small intestinal bowel overgrowth, what it means, how you can test for it, how we treat it. But I first think we need to go into, what is it?
Yeah, SIBO is a condition where the normal colonic bacteria has somehow migrated into the small intestine for various reasons. And it causes about 60% of IBS is considered to be SIBO or suspected to be SIBO. So it's a huge problem for a big population subset that has IBS and doesn't know that it's an actual bacterial overgrowth and is therefore very treatable.
So we're talking about fermentative bacteria that normally reside in the colon migrating up into the small intestine, yes?
Yeah, that's right. Or they're stagnant there for various reasons, such as chronic proton pump inhibitor use or other dysfunctions in the upper gut. But the most common cause of SIBO actually is a post-infectious gastroenteritis type situation where you have a case of gastro and it causes bacterial overgrowth, but also it actually, that's not the bacteria that is the SIBO bacteria. That's more a situation where there is a toxic release from bacteria such as Campylobacter and Shigella, and some of the normal ones that cause food poisoning. And what happens there is that the body, in its attempt to flush out this toxin called cytolethal distending toxin, actually creates an antibody accidentally to a nerve fiber called vinculin. And what happens is the vinculin is part of the normal motility of the small intestine called the migrating motor complex. And so what happens is when you have a situation where you've basically paralyzed the migrating motor complex, then you don't have the normal cleansing wave that sweeps through the small intestine every 90 minutes on an empty stomach. And then you have a situation of bacterial overgrowth just normally happening because they're not normally flushed out. But again, it's important to distinguish that it's not that bacteria like Campylobacter or Shigella, which are known pathogens, reside in the small intestine. It's just normal bacteria such as Klebsiella, Proteus, Enterobacter, those types of species or genuses that we see in the small intestine.
Nirala, from just what you said there, I've got 10 different questions floating around in my head right now, and I think the first one I need to know about is, what is vinculin?
Yeah, so vinculin is a membrane cytoskeletal protein that's found in the small intestinal wall that's part of the enteric nervous system. And this cytoskeletal protein is really important for the nerves there to stretch out and connect to each other so that this smooth cleansing wave can occur. And that's known as the migrating motor complex. So it's this, basically what the migrating motor complex is an assurance that no residual bacteria remain in the small intestine where they're really damaging. So what happens is a very sequential wave occurs in the small intestine that's sort of imperceptible to us. Sometimes people, like a growling, hunger growling, that's often the migrating motor. Yeah. Yep. And so what happens is it's an autoimmune reaction where the body, in its attempt to wash out this poison that's generated by the bacteria that cause the gastroenteritis or food poisoning, it creates an antibody to vinculin mistakenly, because there's a component on the toxin of the bacteria that caused the food poisoning that looks very similar to vinculin.
So it's like a cross-reactivity.
Yes, exactly. So it's truly a case of mistaken identity. It attacks the wrong target.
Right. And when you're saying this is implicated in irritable bowel syndrome, so is this talking about is it 40% of irritable bowel syndrome cases that are attributable to an infectious cause? Is that right?
Well, Dr. Pimentel actually did a study, and what they found is that the most common risk factor for the development of IBS was actually a case of gastro, right? So case of gastroenteritis or infectious kind of situation. That increased the development of post-infectious IBS sevenfold. So that is the most common denominator for a lot of IBS cases.
Right.
And there's some differences in opinions or also demographics, but about 60 to 70, sometimes more cases of IBS are actually SIBO. So that has a huge implication, obviously, for natural healthcare practitioners and GPs, because we see so much IBS in our practice.
I'm seeing a sort of parallel here between the work of Professor Alan Ebringer and his work with ankylosing spondylitis and a cross-reactivity with Klebsiella.
This is a little different in that I think it's a little different in that it's not the bacteria themselves. It's the toxin that they release, right? That causes the body to basically create an antibody against that poison, that toxin. But then causes this kind of cross-reactivity. But not, the thing is, Andrew, it's not all cases have an autoimmune component.
Right.
We see plenty of people, as I've mentioned, that have been on proton pump inhibitors for sometimes years, and that's one of the most important risk factors for the development of SIBO.
So what about with young people? We're talking about the major thing being gastro. Obviously, they haven't been on PPIs, heaven forbid, for years, at least not yet. Yeah, I'll give it 20 years.
Well, actually, a lot of kids that I've seen in my practice were early on PPIs.
Oh, my goodness.
For reflux and for all sorts of digestive conditions as babies, babies that have reflux and stuff. So there are, it's not unheard of to see children on PPIs in your practice.
And what about identification of SIBO? I would gather that it hasn't reached the Rome criteria yet. So how do you differentiate it between other GIT disorders?
Well, actually, it has reached the Rome criteria. They've made some because the development of the breast testing that subsequently came out of that in order to help diagnose SIBO has come out of the Rome criteria.
Oh, really?
So I think one important component there is that Rome criteria really was set up also for the diagnosis of IBS.
Yeah.
Right? And so certain disease factors or symptom pictures had to be present for that. And certainly that they exactly mirror IBS. So one thing that we know is that if you're diagnosed with SIBO, the symptoms are virtually the same as anyone that sees patients in their practice,
Yep.
basically you're going to see postprandial bloating. You're going to see very often abdominal hypersensitivity, alternating constipation, diarrhea. So it's very similar in its presentation. Mm-hmm.
So just for our listeners, it's Rome, as in the city-state, romecriteria.org, and you can register there and access all sorts of diagnostic criteria for functional gut disorders. It's an invaluable resource, along with things like the Bristol Stool Scale and things like that. So, Nirala, if this is an infectious agent and we're talking about gastro, how do you prevent it? Can it be prevented?
Well, as being naturopathic practitioners, of course, we always have this idea of prevention in mind, which is wonderful. And I think the important thing here is yes, we can prevent it. The short answer is yes. If you're traveling and you tend to get gastro, then perhaps you would want to take something like Saccharomyces boulardii. Maybe I usually give my patients bitters or herbs that really stimulate the motility of the upper gut, because that's really the issue, that you don't want anything stagnant in the upper gut. Right. You really do want to move things along, as well as sort of well-known preventative probiotics. I think really have a role. And so that's sort of my recommendation. Dr. Pimentel, who, as I've mentioned, has really brought a lot of this into the natural medicine arena, but also because, I think anything in modern condition a long time to really take root there. So he was very welcomed in the natural medicine circles. And so the SIBO symposium that he has attended was very well received there. And so we've really started to disseminate a lot of this information in our integrated medical circles. And I think that's really helped a lot, because now we see that patients are coming into their doctor's offices and they understand SIBO, and we still see a lot of practitioners that just are not familiar with this condition.
Okay, but you mentioned commonalities there between irritable bowel syndrome, and notwithstanding that we don't have the capacity to diagnose medical conditions, but I'm seeing parallels there with irritable bowel syndrome with regards to the fluctuation of alternating constipation, diarrhea, borborygmus, foul-smelling stool that you might have, that sort of thing. What are the key differentials that you see in your case history that might go, look, that's SIBO and not, let's say, Campylobacter, let's say the active infection?
Well, active infection is usually quite self-limiting, right? So you're going to have a case, and then it sort of peters out, and then you go back to normal. And then often there is this sort of break in between active infection and the development of SIBO that can take months, actually. But I think the key differentiating factors that I see in my practice, and that are sort of like little light bulb moments. Oh, hey, wait a minute, this is actually SIBO. Would be things like patient reports, I have constipation, I'm supposed to take fiber, and fiber just bloats me up. Right. What happens there? The fiber gets fermented by residual normal bacteria that are not meant to be in the small intestine, but are in the small intestine, right? And another clue might be that they received a case of or received a course of antibiotics for an unrelated condition, but their digestive symptoms improved temporarily, right? I often ask that. So, and then there are sort of, associated conditions such as interstitial cystitis and acne rosacea and restless leg syndrome that are very highly associated.
Restless leg syndrome?
Mm-hmm.
Wow.
Yeah. So, and things obviously like diabetic enteropathy and, I mentioned fibromyalgia, non-alcoholic steatohepatosis. So there's a host, but, those conditions are more broad, but especially interstitial cystitis. Why? Because it's another mucosal disturbance, right? And with acne rosacea, that's a huge connection there. So those conditions, I would always specifically ask about digestive disorders.
Yep.
And do you have bloating right after meals? How quickly after meals? So those would be more differentiating factors between somebody who has maybe large intestinal dysbiosis, where we see bloating that just occurs towards the end of the day. Their clothes are fitting a bit tighter at the end of the day. I mean, that can just be a functional digestive disorder, but typically we will see some hypersensitivity and some abdominal pain as well with SIBO.
Yeah. Okay, so how would you test then for SIBO versus, let's go back to IBS? How would you differentiate between those?
It's a really good question, because no test is perfect, right? And one thing I will say here for practitioners listening, you can't do a stool test and know anything about the small intestine.
No.
The situation is so vastly different. They're like two different countries.
Yeah.
It's completely different. Yeah. So sometimes you get little clues on a CDSA or complete digestive stool analysis that that could lead you to think, okay, maybe I should investigate this a little further. But the only really handy tool that I use in my practice and recommend practitioners use is a lactulose breath test and a glucose breath test.
Right.
And the reason for that is that the bacteria that cause SIBO, again, they're normally found in the large intestine. So we're talking about Aeromonas and Klebsiella and Proteus, and they're gas producers, right? They produce, when they ferment residual food that's not been swept out from the small intestine, or because the brush border has been damaged and therefore you lack the enzymes to digest the residual food, they just have a field day with that, right? And in their process of fermentation, they produce hydrogen gas. And hydrogen gas is very damaging to the microvilli of the small intestine. So they not only cause damage there, but they also cause something called deconjugation of bile acids. And so eventually you're going to see, issues with malabsorption of essential fatty acids and fat-soluble vitamins. But back to testing. So whilst they're doing their fermentation, you can actually capture hydrogen gas beautifully on a breath test. Mm-hmm. And how that's done is the patient goes through a period of a day. If they're diarrhea dominant, which is usually the case with hydrogen dominant, let's say alternating patterns. They're not always having just chronic diarrhea, but more of an alternating pattern with diarrhea dominant. They will very often be hydrogen dominant. And so what happens is they fast for a day before the test, and then they fast overnight, but they have a prep diet the day before in an attempt to sort of have a bacterial reduction. And then they get up in the next morning and they do this breath test, which involves drinking a lactulose substrate, which causes a temporary bloom of the bacteria. Mm. And then they capture their breath every 20 minutes. And then depending on where we see this rise in hydrogen, we can determine if it's in the proximal ileum, if it's in, where we are looking at in the small intestine. So it's a great useful tool. It's not 100% accurate, right? No test is 100% accurate. Yeah. I'll also say that the other bacteria that often is present in SIBO is called Methanobreviibacter smithii, which is not really a bacteria per se. It's in a whole different class in and of itself. It's in a class called Archaea, which include a lot of the thermophiles. These are bacteria that really love extreme environments. And they're also, years ago, we've known about Methanobreviibacter smithii in its role as an obesogen because it's so effective in extracting calories from food. So it causes methane or methane rise. Yep. So at SIBO test, we measure hydrogen and methane gases. Mm-hmm. And there is a third gas, which is hydrogen sulfide, which we cannot really assess for yet using a breath test.
Right, which would just be horrible.
Well, no, it's just a third gas that is often present, and those are usually the extreme egg-smelling gaseous emissions that people talk about. Yep. But it's just we're not able to capture that yet using our technology.
Okay, so I have to ask there. There was a breath test for Helicobacter pylori. How does this cross-react or confuse that diagnosis?
Okay, totally different, right? Because with that breath test, you're actually giving urease as a substrate. It's a completely different test,
Yep.
right? So you're not measuring hydrogen and methane, and you're not doing a timed event like that. So even though it's still a breath test, but it's not that breath test. It's a completely different focus.
Right. And so you mentioned that the Rome criteria has taken this up now, and it's really gaining ground. Where is the body of evidence leaning to now? Like, what are we looking at here?
Well, first of all, as you know, I mean, just even at the last Bioceuticals Research Symposium, which was really fantastic, I mean, all the speakers, it's in all of our sort of consciousness now that the microbiome and bacterial involvement in pretty much every physiological function in the human body. It's just this incredible excitement right now in medicine, I feel, that we are starting to really understand some really fundamental issues with the microbiome. And so that's having said that, that's really exciting.
Yeah.
What the issue is with SIBO, and there is still a lot of, there's not a lot of agreement across the board in terms of standardization of the test,
sure.
right? So there's a huge body of evidence in terms of studies and research. Research is everything from stunted growth in children to the development of gallstone to as it relates to SIBO, right? So there's a huge amount of research that's really gone into looking at SIBO, and because IBS has been around for quite some time, and without many tools that conventional medicine really has to offer for IBS sufferers.
Yeah.
So I think that's really the impetus behind that, because it's such a prevalent condition that we are seeing a lot of research going into SIBO. So I think we're going to get more information as time goes on. But there is not really a standardization. But of course, we know the general framework of timing of the test and the substrates to use and the grams of the substrate and all of that. And there is some consensus, about using lactulose breath test only versus lactulose and glucose in succession.
Yeah.
You never use them together.
Yeah.
And then there are other schools of thought that really are completely against the lactulose breath test alone and only think of that as an assessment for motility. But I think generally speaking, I think it's a really useful test for practitioners to give them some guidance as to, okay, is this SIBO? Because SIBO is really a different condition from large intestinal dysbiosis or even just candida, although very often with SIBO, you can have SIFO, which is small intestine fungal overgrowth, right?
Oh.
So those two conditions often occur together.
Right. The area of the microbiome is just starting to sort of see on the horizon of research now. What I think is interesting is when you see such eminent scientists as Dr. Alessio Fasano, who's working in standard gastroenterology, pediatric gastroenterology, and he's famed for his work with celiac disease and wheat sensitivity and non-gluten wheat sensitivity. When he starts to mention things like SIBO, that's when you start to take notice. And I had a really interesting interview with him at the symposium, and he was talking about it, and I was going, wow. So this is bigger than what I thought it was, for sure.
Yeah, no, I listened to your podcast. If it was the one that you recently did, it was a great interview. And
he's awesome.
I have a huge amount of respect for Dr. Fasano. I think he's, I had respect for anyone that goes out on a limb and is curious and really follows that, because a lot of those scientists they cop a huge amount of flack initially. Yeah. When they put forth their theory, and I think. And one really fascinating part of that, of course, was where he talked about that there are really two conditions where we see the release of zonulin, and one of them is SIBO. So for me, that just cemented the fact that me as a clinician, I'm going to if I see somebody with systemic symptoms, perhaps that's generated by their digestive tract, I'm going to be thinking about testing for SIBO, and I'm going to be thinking about testing for zonulin. And the connection between leaky gut and SIBO is very well established.
Yeah, so this is the thing: is like, what do you test for, and how does that change your treatment plan? I think I will dub Dr. Alessio Fasano the god of the gut, but well,
I wouldn't go that far. I think he's the god of Zanu for sure. But I think it's a deity ruled kingdom, I think, or or a place, because there's a lot of amazing people that have done so much amazing work. But back to the testing, the reason why you would test for SIBO, because I get this question actually a lot from practitioners, because I do a lot of webinars and I do a lot of master classes around this. And one of the common questions is, why don't I just treat for it, right? I mean, if I think it's SIBO, why wouldn't I just treat for it? Treat it and then see if it resolves. But the problem here is that if you just treat it without really understanding, A, is it methane dominant? B, is it sort of a combination of hydrogen and methane? What's really going on? And C, how high are those gas levels, right? So, for example, if you're treating and you're seeing great results and you prematurely stop the treatment, you're going to have a relapse. And it's a very high rate of relapse. SIBO is one of the most common relapse conditions in the gut that we see. So I often say, look, get a baseline to understand, A, how high is your hydrogen level, because that gives you an idea if you're what type of bacteria you're dealing with. If it's very high in methane, it's Methanobrevibacter smithii, that it also uses hydrogen to create methane. And so it gives you treatment guidelines, because you're going to treat it, you're going to use different antimicrobials for methane-producing bacteria, for this condition, than you would for hydrogen-dominant SIBO. So it's a really different condition that requires different treatment.
So we really need to be testing a baseline before treatment to aid in your dare I say the word diagnosis, naturopathic diagnosis, whatever.
Yes.
And then you need to
assessment,
thank you. And then we need to be doing what are you talking about, 3 month during treatment or 3 months post-treatment?
Yeah.
Yep.
I look at it in terms of a protocol, right? So I've developed and this has just come out of, one of my mentors or people that I really want to give a lot of credit for is Dr. Alison Seebecker. And Dr. Seebecker is a naturopathic colleague, another naturopathic doctor from the U.S. who, I remember, and you asked me how did I get into this? Well, actually, it wasn't because I read Dr. Pimentel's book initially. It was really that I went to the American Association of Naturopathic Physicians conference, I think it was 2011 or so, or maybe even 2010, and listened to her talk about SIBO, and I was just dumbfounded. I was just like, why have I never heard about this? And so that really is what started the journey for me. And I think in retrospect, I was sort of like, we all have patients that get better without treatment. And then there's just a subset that just doesn't. Yeah. And we're actually seeing more and more of these really kind of difficult cases. And I think a lot of those cases that you think are gut related and you think maybe they're candida or just simple dysbiosis and they just don't get better, I think a lot of those are SIBO.
Yeah.
So that is what sort of started it all for me. And she's been really instrumental in bringing that also to our attention in terms of the integrative medicine community. And she's on a lot of podcasts, a lot of web sites, and she is the author of she's just actually writing a book, Natural Treatment of SIBO, that we're all anticipating. And she has a website called SIBOinfo.com. So there's a lot of information there. But getting back to treatment, so really there's two types of antimicrobials, right? So you have your conventional antimicrobial. If you have a hydrogen-dominant SIBO case, and you happen to be a GP, then you might want to consider using a course of rifaximin or Xifaxan, which is an antibiotic that I actually think is a very good antibiotic because it's a bile-soluble antibiotic, and therefore we don't see this type of dysbiosis that we typically see with other water-soluble or broad-spectrum types of antibiotics. So it's a fairly safe antibiotic that's really effective for killing off hydrogen producing bacteria. And for methane, conventional medicine isn't all. I mean, yes, there is an antibiotic called neomycin, and that's often used in conjunction with rifaximin, but we don't see the results with that. And it's actually much harder to treat Methanobrevibacter smithii infections. So what we do then herbally, we have a huge plethora of our herbal repertoire that's really effective in treating SIBO. And so for your hydrogen producers, you can use berberine-containing herbs such as Oregon grape or golden seal or coptis or philodendron. So it's really a huge amount of herbal pharmacopoeia there that's very effective. And then also pomegranate and manuka and horopito. And so what I love about herbs is that you can really tailor it to every patient. If you think that patient has SIFO and SIBO, you can really beautifully combine something. And there's a lot of products on the market that are very effective in treating it herbally. And there was actually a study done by Dr. Mullen in Johns Hopkins University that clearly demonstrated that herbs are as effective as rifaximin. Now, when we talk about Methanobrevibacter smithii, or just let's say methane-dominant SIBO, which is typically constipation-dominant, right? So studies have been done where animals were infused with methane gas and every single animal became constipated with the infusion of methane gas. So we know it's terribly constipating. And what we have in our armamentarium is garlic and oregano oil and cinnamon and things like that. So I think natural medicine really shines. Personally, I think that this is really where we do shine in the treatment of digestive disorders. So, and what I've then also created is the biphasic diet approach, because what we know is that bacteria and archaea, well, not so much archaea, but the bacteria that produce hydrogen love to ferment fibers. And this is where the FODMAP diet really comes in very handy. But as you and I know, the FODMAP diet is not meant to be used long-term, right? Because what are we doing? We're starving other bacteria as well. So the FODMAP diet is really designed to stop the fermentation process by these bacteria, right? But we want to have a beginning and an end, because we need to also feed other bacteria that really thrive on these fibers, and fiber is very healthy, as we know. But so what we do is I've created this what I call the biphasic diet, and it really should be called the triphasic diet, because the biphasic diet is phase one is where I basically, let's say that a patient comes to me and I think that I've tested them for SIBO. Yes, they have SIBO. So I start them off with a month on just extremely low FODMAPs. And I also include digestive healers, as we know, things like glutamine and things like potentially turmeric and maybe zinc carnosine and zinc in general. And probably also some digestive enzymes and potentially hydrochloric acid and things that we know how to do as naturopaths. And then after a month is up, then I move them into phase two, which that's when I start to utilize my antimicrobials. And I loosen up the diet to provoke a little bit of bacterial growth. And I found that approach to be very effective. So then after another month, maybe 4 to 6 weeks of antimicrobial treatment, I then retest to make sure that SIBO is gone. And then I put them on something called prokinetics, right? So prokinetics is a class of either herbs or conventional medication that's meant to improve the motility of the small intestine, so that you're really resetting this entire system.
I know this goes right back to the beginning, but this SIBO smacks of an issue with microbial resilience, or an aberrance in microbial resilience. And this has been well talked about with really good researchers like Martin Blazer and Fred Backup and Clara Belzer. They're all these fantastic researchers of the microbiota. I like the point that you're doing a baseline and a treatment. But you did mention a couple of antibiotics there. How do you accomplish this if the groundswell isn't ready for Australian GPs to then prescribe these antibiotics for patients?
Well, rifaximin just got FDA approved in America, right? So that usually is a good indication that that Australia will follow suit.
Approved for SIBO?
Approved for SIBO.
Oh, right.
Yes.
Okay.
Mm-hmm. Yeah. So this is definitely entering the realm of the conventional medical doctors.
Yeah.
Actually, at the Super Bowl in America, a huge sports event, they did have an ad for rifaximin, which is like, how mainstream can you get, right?
Only in America.
So it's like, America is littered with advertisement for medications, quite horrific. But anyway, so that's something that is beginning to really enter into the consciousness of the conventional medical practices here. That's definitely the case.
Right.
But it does take some time, and patients do tell me that they've told their practitioner, their GP, that they have SIBO, and they're like, "What? I've never heard of it."
Yeah, and certainly in Australia, it'll take ages.
Yeah.
Yeah. What about the risk of initiating a serious infection like Clostridium difficile, C. diff?
Me being a naturopathic doctor, so I actually am always championing the cause or the use of natural treatment. So I'm not saying that it's preferred over that antibiotics are preferred over natural treatments, because natural treatments are just as effective, right? And probably will cause less harm. In fact, that is the title of my talk when I'm going to Portland, Oregon this year, is like, sort of, let's remember that herbs are have been our champions for a long time. They're very effective. I will say that the reason I brought up rifaximin before is because, there are a number of thousands of people who could potentially be helped by rifaximin, right? And because GPs are not trained in the use of herbs. So that was my reason for bringing up conventional treatment, because it is really very, very helpful. And I personally, from what I understand rifaximin to be, I understand it to be an antibiotic that does not cause the typical dysbiosis and C. difficile that we see with broad-spectrum antibiotics.
Right. Oh, so it's a narrow spectrum.
Well, it's a different class of antibiotic. It actually gets dissolved in bile and therefore is only active in the small intestine. By the time it reaches the large intestine, it's ineffective, right?
Gotcha.
So it doesn't cause that.
Gotcha.
I sound like an ad for rifaximin when I really want to be an ad for herbs, right? So
no, but these are salient points, and practitioners need to know them. So, I think that's a really good point to know that it's basically done with by the time it reaches the huge fermentative bowl of the colon.
Yeah.
So
and I will say though that on my website SIBOtest.com, any practitioner can create a free account and listen to a 90-minute webinar as to what is SIBO, because I would never recommend anyone to just willy-nilly treat SIBO, even with rifaximin, because the recurrence rate is just too high and it's not worth it, right? So it's not that you just do that and then you're done and dusted and you move on to the next thing. You do need to know what you're doing, because you still have not reset the migrating motor complex, right? So that still is important to do, and you still need to have some dietary recommendations handy for your patients so that they really minimize their risk of recurrence.
You know what? I think this is a call to action for anybody interested in treating, I've got to say, any functional gut disorder, to know at least when it's SIBO or SIBO and when it's not, is they need to, log into your website. And so that's SIBOtest.com. Is it .au?
Yeah, so SIBOtest.com is our online testing service, and we really pride ourselves to be there for the practitioner. We have a lot of free educational resources because we really want to further the cause. We also have an online database that's searchable by any patient for a SIBO treating practitioner near them. And that's all free to the practitioner. And, they can just get the information. They don't necessarily have to order through us, but they can just get the information so that they really understand how to treat it safely and effectively.
And I think also there's a SIBO summit happening in Kingscliff, correct?
No, the Kingscliff one, you're getting it confused with the Australian Naturopathic Summit.
Whoops.
That's in Kingscliff. The SIBO Summit is, I'm actually very excited about this summit. It's the first SIBO Summit in Australia. It's in Melbourne on October 8th and in Sydney, October 10th. And it's myself, Dr. Siebecker, and Dr. Jason Horlak, who is certainly an undisputed expert in pre- and probiotic use in Australia. And he's quite well known here as well. So it's this very well-rounded approach to how to really get a good handle on how to treat your patient. Additionally, we have some guest speakers, and one of those guest speakers is Alyssa Tate, who's a naturopath in Brisbane, who does a lot of work with adhesions, because we haven't really touched on other risk factors for the development of SIBO. One of them being adhesions.
From abdominal surgery, right?
Yeah, exactly, or endometriosis. And where you create a scar tissue that adheres to the small intestine and creates sort of like a kink in the garden hose type of situation where it's not, the motility is really impaired. And she will be talking about treatment of adhesions. And she is just fantastic. I've sent a lot of my patients to her for working to loosen these restrictions with really great results. So I'm excited to have her present at the summit as well. And you can, if people are interested, they can just go to sibotest.com. There's a lot of information there about the summit.
And, great. Okay, so that was what I was going to ask, is how can they get in touch to register for the summit? Because I think that's going to be just mandatory for naturopaths to attend. Has anybody looked at possible changes in the mucosal composition of the small versus the large bowel? Because there seems to be in the small bowel sort of one, let me say, layer, whereas in the large bowel there appears to be two layers, certainly a more robust layer, as well as the quite liquid or fluid layer. So does there appear to be any changes in the composition of that mucus layers?
Well, what we do know is that the changes that occur when people have developed SIBO are very much related to the damage caused by the gases, right? So the gases themselves are damaging to the microvilli. So these are the little villi on top of the villi. Yeah. So where we see real issues with malabsorption, particularly with B12 and folic acid, zinc and magnesium, as well as essential fatty acids due to this deconjugation of bile acids. That's another cause. So we know that happens. And we also know that zonulin is released in bad cases of SIBO. So I would say that there are definite changes that are indicative of SIBO. Whether or not there are any others, I'm not aware of that. I wouldn't be surprised, but I'm not aware of anything else specifically other than the damage that it causes. And, the other thing about that is that we see actually a huge release of interleukin 6 and 12 and other sort of inflammatory cytokines that are undoubtedly involved in what we think of as sort of systemic clues to SIBO, and that would be fibromyalgia, as I've mentioned, and other conditions where inflammatory cytokines are often present. So there's this interplay between systemic and local situation as it relates to the mucosa that we don't fully understand yet, but we're seeing it sort of en masse with things like autoimmunity. And there's, like I said initially when we began this interview, that there's this tremendous excitement that I think you and I, as sort of holistic practitioners, have known about for a long time, and our profession has known about this for a long time. But to actually see this really come out in research is just a tremendously exciting time for us.
Just one question before we wrap up, Nirala. There's so many questions I need to ask, and we just have run out of time. But I'm just wondering, you said that SIBO could result in the release of zonulin, and I'm wondering if this might be that answer for those patients that suffer from a non-gluten wheat sensitivity, where it's not reacting specifically to the gluten, but they still are sensitive to wheat?
Yeah, like I'm not entirely sure. I cannot answer that definitively, but there are other subsets of proteins that are non-gluten related. So this is more like wheat germ agglutinin.
Yeah.
And what I understand wheat germ agglutinin to do is more sort of like I can't really intelligently talk about that because I'm not entirely sure. But the way I understand it is that it does more like sort of a direct damage to the intestinal lining.
Right.
So there's still like a damage, but that doesn't result in zonulin release, because you can have all sorts of reactions that are not necessarily related to zonulin, right? So what I would expect to see then with any condition that has zonulin release as part of it, that we would see some systemic symptoms as a result of absorption of things that aren't meant to be absorbed. And for those listeners who don't maybe not follow us, but zonulin is a really integral part of keeping the tight junctions tight. So in between gastrointestinal cells, so that we don't have anything absorbed into the body that's foreign. So when that gets damaged, we start to see sort of intestinal permeability and leaky gut, and then we start to see a host of problems associated with that, involving the immune system and LPS absorption and all sorts of things that can cause damage. So I can't really, I don't feel qualified to answer that for sure, because I have not come across that as the cause for symptoms in a non-gluten wheat sensitivity.
I really think that all practitioners out there need to log on to SIBOtest.com, and they need to register and download the free information that you have to offer, Nirala. But I think also that it should be mandatory for all Australian practitioners to attend the SIBO Summit in October. I think it's going to be invaluable for their practices.
Yeah, it's a really great time to be involved in anything related to the digestive tract, because I feel like in some way we're being vindicated. We've been talking about this for a long time, and we didn't have a name for it. We didn't know it was SIBO, but I think that naturopathic medicine, or any kind of holistic approach to SIBO and other digestive disorders, really, it's very timely. It's really important that we step up and we become very well versed in this condition, so that we can not just help as many people as possible, but also that we showcase what's in our sort of natural armamentarium. So I'm really excited to be able to offer this to people, and to also see where all this research goes. It's just fascinating.
Dr. Nirala Jacobi, thank you so much for joining us on FX Medicine today.
Thanks so much, Andrew.
This is FX Medicine, and I'm Andrew Whitfield Cook. If you've enjoyed what you've heard today on FX Medicine, please engage with us and let us know what further topics you'd like us to cover. You can get in contact with us through our website, fxmedicine.com.au, or look for FX Medicine in your favourite social media platform. You can also rate and review us on iTunes, and we'd really like to thank those who have already rated us. It's through your continued support that enables us to bring you current, complex and relevant topics to enhance your practice of natural medicine.